Good afternoon to everybody. I'm Dr. Abhinesh. I'm doing fellowship in pediatric pulmonology in Institute of Child Health. I'm presenting a child who was on ATT with persistent fever, the deceptive paradox. I'm presenting this patient on behalf of Department of Pulmonology, Institute of Child Health. Here is a 15-month-old child who is born of non-consanguineous marriage. Child was previously well. Child was evaluated elsewhere for fever which lasted for 2 weeks duration without any focus, with history of a poor appetite and poor weight gain. The significant history of contact with maternal aunt being drug-sensitive tuberculosis on ATT. These were the investigations. His MAN2 was positive. Chest X-ray showed hilar lymphadenopathy and right paratracheal lymphadenopathy. RGJ CB0 was negative. COVID was negative. Child was started on ATT with the diagnosis of clinically diagnosed tuberculosis. This was the initial X-ray. Here we can see right hilar lymphadenopathy and there is a right paratracheal lymphadenopathy. So child was started on ATT. After 1 month of ATT, child continued to have persistent fever spikes with no improvement in weight and appetite was still poor, but child was non-toxic. So the child was referred here for further management. Here on arrival, child was not sick looking. There was no significant lymphadenopathy or external markers of tuberculosis. BCG scar was present. Examination, systemic examination, all were normal. So here is a 15-month-old child with fever which lasting for almost 50 days with a significant contact history, that is drug-sensitive tuberculosis, with the chest X-ray showing mediastinal and hilar lymphadenopathy, with the MAN2 being positive. Hence, the diagnosis of clinically diagnosed tuberculosis was made and was started on ATT. It was appropriate for the last 1 month with no radiological or clinical resolution. So what are the possibilities? These are the two things that we were considering before proceeding to investigations. One, whether it is tuberculosis. There is ample evidence, but there is no microbiological evidence. If tuberculosis, why the child is not responding to ATT for 1 month? Now, these were our initial investigation. Initial investigation, CBC was normal except for elevated total count. ESR was elevated. Renal function test and liver function test were normal. USG abdomen was normal. This was our repeat chest X-ray. Here also we can see the right hilar lymphadenopathy and right paratracheal lymphadenopathy, which is not resolving. We also investigated for other causes of pyrexia of unknown origin. EBV was negative, Brucella IgM was negative, blood and urine culture was sterile. We repeated an RGJ CB0, which was also normal. So we proceeded with CECT. In CECT, here we can see right paratracheal lymphadenopathy with the central caseation, so which was also more in favoring tuberculosis, and there was also minimal bilateral upper lobe consolidation. So with this, the diagnosis of clinically diagnosed pulmonary tuberculosis was more evident. So these are the points favoring that, which is long duration of fever, which is more than 2 weeks fever with poor weight gain, that is presumptive tuberculosis, with the contact positivity and MAN2 being positive, with the radiological evidence of mediastinal lymphadenopathy with central caseation. Points which are not favoring where there are no microbiological evidence and there is no response even after 1 month of ATT. So hence we thought we will proceed with a proceed to try to find out the microbiological evidence. So we proceeded with BAL. BAL for CB0 and midget were sent. CB0 came to be negative. Now these were the fever spikes after 1 month of ATT, which is still persisting. So, so we looked into causes for non-responding tuberculosis, that is after 1 month of adequate ATT, why the child is not responding to tuberculosis. These were the points that we consider. Is this a non-response tuberculosis? Yes. Yes, there is no clinical response after 4 weeks of ATT. Is the patient taking his pills correct? Yes, pill count was correct, duration was correct, regimen was correct, and the complaint was also good. Yes. Is this a true non-response TB or a non-TB? We have seen previously there is ample enough adequate evidence that this is a tuberculosis. Is the symptom persistent due to unaddressed comorbidity or new infection? There is no evidence for new infection or new worsening. and there is no evidence for primary or secondary immunodeficiency. His HIV was negative. Is this a paradoxical reaction? Less likely, as there was no apparent improvement after starting ATT. Is this a drug-resistant TB? We tried to find out the sensitivity pattern of the contact, but it was traced and it was rifampicin sensitive. Midget of our child was awaited. This is the niche where the contacts details were updated. Here we can see the sensitivity, rifampicin resistant not detected. Using the phone number or niche ID, we can easily trace the sensitivity pattern of the contact. Now, how to proceed? We still didn't have any microbiological evidence. We thought we could proceed with a CT guided biopsy. But before doing that, we thought we will proceed with a pharmacokinetic study. Pharmacokinetic study is nothing but therapeutic drug monitoring, which we usually do for vancomycin or amikacin. This will provide the drug level, whether it is adequate drug levels were reached in blood, uh, blood or not. This we can find out by pharmacokinetic study. This can be impaired when there is an altered metabolism or poor absorption. So we proceeded with pharmacokinetic study. Meanwhile, we discharged the child on ATT. Our plan was to proceed with CT guided biopsy if pharmacokinetic studies were normal. This was the pharmacokinetic study report. Here we can see the drug levels at 0R and 2R and 4R. Usually 0R is the baseline level, which is taken before giving ATT. And then we will take another 2 samples, which is at 2 hours and 4 to 6 hours usually. This usually all the ATT will peak by 2 to 4 hours. So we can see the peak level by around 2 to 4 hours. And we will have another 6-hour sample, which will tell about if there is any delayed absorption or the half-life of the drugs. Here you can see the drug level of the rifampicin and isoniazid. Rifampicin, isoniazid, pyrazinamide, all were well below the therapeutic range. In the therapeutic range of rifampicin, you can see it is 8 to 24. Here the maximum is only 0.76. The same for isoniazid and pyrazinamide. So therapeutic drug concentration were well below the therapeutic range. So these were the previous dose. Here you can see the previous dose where the drug levels were isoniazid 11 mg per kg and 17 mg per kg and 34 mg per kg, which we modified after receiving the PK study report. We modified the dose of the drugs. That is, we increased the dose of rifampicin, isoniazid, and pyrazinamide. After modifying the dose, we reviewed the child after 7 days. Fever settled, appetite improved. So coming to therapeutic drug monitoring in drug-sensitive tuberculosis, why it is needed? It is needed because there is evidence that interpatient variations in drug levels in blood were observed. This is either because of poor absorption or rapid metabolism. Whom it is needed? It is needed in patients with severe disease where adequate blood levels were needed even early in the treatment, or in patients who are non-responding to TB to ATT, that is 4 weeks after starting ATT. How it is done? As we have seen earlier, 0 level, 2 hour and 6 hour sample will be taken. 2 hours will usually provide the peak level, and 6 hour will tell about the delayed absorption or half-life. These are the factors which are stated in influencing drug levels: malnutrition and micronutrient deficiency, HIV, malabsorption, or polymorphism in NAT2 genotype, that is rapid acetylase, where it will be rapidly metabolized. Thank you.